Thank you. Sorry, everyone. I guess I'm aphasic when it comes to computers, but I thank everybody for joining me today. So my name is Carolyn Brockington, and I am the director of the Stroke Center at Mount Sinai West and Mount Sinai Morningside. And I thought I'd give you a little bit of information regarding some advances that we've had recently in acute stroke treatment over the last few years, as well as sort of what's happening at Mount Sinai Morningside and Mount Sinai West. So it will give you a little insight as to why you always see the stroke team running around like crazy when we say that time is brain. It really is. So thank you for joining me today. So I don't have any disclosures. And I think everyone starts off with this slide because it's a big problem, stroke, right? If we say that more than 700,000, and that's just ischemic strokes, occur annually in the United States. If we think back to IV thrombolytic therapy, TPA, which was the study, which we'll talk about briefly, was in 1995. The approval from the FDA was in 1996. And it's since that time, so what, 27 years, really we're still just treating about 1 to 8% of patients with IV thrombolytic therapy, not only in New York, but sort of across the country. So that's a relatively small number. So what causes a stroke? You know that most strokes are caused by this thromboembolic occlusion of an intracranial artery. And so I like videos. I don't know if this is going to work, but if we think of a thrombus, organized thrombus, and then a piece of that's going to break off as an embolus, right, and go distally to a distal blood vessel, obviously obstruct blood flow. And if that vessel is going to the brain, people can have a potential stroke. So that's what we mean by thromboembolic occlusion. And this is interesting to me. You know, the target of stroke therapies, if it's IV thrombolytic therapy, if it's endovascular, if it's neuroprotection, et cetera, is not the stroke, right? The stroke means that that's the part of the brain that's been irreversibly injured. Our target is really what we call this ischemic penumbra, which is the area that surrounds the stroke that is receiving some blood flow, but probably not enough. And if we can reestablish blood flow, we can really reduce the size of the stroke. So again, if we go back to our video and where we have the thrombus and causing the distal occlusion, that part of the brain initially is going to be the infarcted area, right? But around that is the penumbra, and that's what we're really targeting in terms of trying to reestablish blood flow and hopefully reducing the stroke size and therefore the disability that somebody might have from it. So I like to think of things simply. If you think of the stroke as the ischemic core, so a bullseye, so that's the innermost. But if we think of all the circles around the bullseye, if we're really able to reestablish blood flow during a period of time, we can shrink the stroke size to very small and hopefully minimal or no deficit. So that's really the target of both IV thrombolytic therapy, endovascular treatment, and neuroprotective strategies. So collaterals are key in stroke treatment. And again, you know, you think of it like you drive down the West Side Highway, you get stuck there, right? But you go the side streets, I can still get home. So the big thing is that if you have a large vessel occlusion, a large vessel obstruction, if you have smaller blood vessels, collaterals that go into that territory, you probably can last longer in terms of not having a big stroke and also allowing us time to intervene. So if we just look at the top, those are CTAs and then subsequently an MRI. So you see at the top left, that's a CTA showing a right MCA occlusion. And then the middle scan shows that we don't have a lot of vasculature in that territory in the right MCA, right? And then subsequently, the MRI shows a rather big territorial right MCA stroke. But if we look below and someone who has good collaterals, that CTA is showing us an abrupt left MCA occlusion. And that person has fairly good collaterals and really results in a relatively small stroke. So collaterals are not something that we can buy at the store, right? Either we have it or we don't, but it allows certain people to do better in stroke versus not, and really just a variation of vasculature and some other things. So why do we always get a CT non-contrast? One, you know that it's fairly quick. Two, it's allowing us to see blood. Obviously, we can't give thrombolytic therapy or blood thinners and somebody's bleeding. But it also, we're looking for really acute early ischemic changes. You probably know that if someone come into the ER right now and they're plegic, they can't speak, they have a gaze preference, if it just happened it would be very unusual to see anything in the brain, meaning I would expect the CAT scan to be basically normal. But as time goes on, you start to see the difference. For instance, if you think of your hand getting hit and it hurts, obviously it hurts initially, but the bruise develops later. The same thing on CAT scan. Even though someone can come in with significant focal neurological deficits, the actual stroke that we see on CAT scan develops later, maybe hours later, maybe a day or so later. So that's why you don't initially see it on CT. But we're doing it to see both ruling out hemorrhage and also looking to see, do we have early stroke signs. Then we do CT angiography at the same time. So a CT non-contrast takes less than a minute. Adding on CT angiogram takes about maybe 2 more minutes, so 3 minutes total to scan. Pretty fast scanning, but it gives us a lot of information if you think just basically plumbing, right? We want to know someone had a stroke, but now we want to know, is there a large vessel occlusion that is causing the stroke? So we can try to tailor the therapy based on that. So the sort of the downside of CTA is that we have to give contrast. And you probably know that in acute stroke, we don't wait for the BUN and creatinine because, you know, as we said, time is brain. So I know that, I don't know if any budding nephrologists are online, but we say neurons over nephrons for stroke because at that moment, we're more concerned about the brain than we are the kidney. So we go full speed ahead in getting the CTA many times when someone comes in with a stroke code. So that's why you'll say that we say we're not waiting for the results of the BUN and creatinine because we want to see what the vessels look like. Also, CTA is probably better than MRA at seeing sort of high-grade lesions and occlusive lesions. And at the same time, we can add what we call perfusion imaging. So again, we looked at the brain with CT scan, we looked at the arteries or plumbing with CTA. Perfusion allows us to see what we were discussing before, that penumbra. Do we have a target? So if you look at on the right side where there's all the red on the lower half of the screen, that's our penumbra area, meaning that's the part of the brain on the left hemisphere that's not getting enough blood flow. So if we're able to reestablish blood flow during that period of time, we would be able to decrease someone from having a large hemispheric stroke versus a relatively small stroke. So in the ED, we get CT scan of the brain, CTA, sometimes depending on time and onset, et cetera, we do perfusion to help us decide is there penumbra involved. So our options for acute ischemic stroke treatment are really the IV thrombolytic therapy, which you know is FDA approved up to 3 hours, and sometimes we can extend 4.5 hours from symptom onset. What we call bridging therapy, which is that IV thrombolytic therapy plus endovascular treatment, usually thrombectomy. And then sometimes if someone's on anticoagulation, you know that they are not a candidate for IV thrombolytic therapy, or if they're out the window of that time, and we can give, or we can try to pursue thrombectomy without any thrombolytic therapy. So that can be 6 to 24 hours. And again, it depends on the person, how good their collaterals are. Do they have an ischemic penumbra and some other things? So the problem is, yes, we have to treat fast because the brain is without enough blood flow. Obviously, you know that the sequence of events in terms of injury are fairly quick. And so the real question is, how do we give something faster and how do we reopen the arteries if needed? So you probably know this time is brain, and it really comes from, they say every moment that goes by that the brain isn't getting enough blood flow, about 1.9 million neurons are dying. So we have a lot of them, but we don't want them to go that quickly, right? So really each minute, and I find this statistic interesting, that each 15-minute decrease in treatment delay provided an average equivalent of 1 month of additional disability-free life. So really the faster that you treat somebody, the better chance that they have of doing fairly well in terms of their stroke and recovery. So you probably know that our endovascular colleagues actually sit at Mount Sinai East on 5th Avenue, but strokes occur everywhere, right? So we have to try to figure out how do we get the treatment quickly. And what we've decided is that the endovascular team comes to us. You know, I'm a native New Yorker. I love New York, but sometimes to get from the east to the west side across Central Park, you can go to London faster, right? It's a lot of traffic. It's a lot of problems. So if we get them to sort of get in a subway or this or that to come over, we can get them faster than we can actually get the patient across. So what happens is, let's say that we have a stroke code at Mount Sinai West that we think is endovascular. It's an option for endovascular treatment. While we're doing the pictures and getting the everything ready, we're calling endovascular and saying we have a case for them to come over to do it. So they bring over the endovascular surgeon, they have an assistant, they have a nurse, etc., and they go to the different sites. So you probably know that West has a angio suite, Beth Israel does. Morningside does not, so they transfer the patients to West or East, and Queens has a new site, et cetera. So it's a lot of travel for them, but really we've been able to bring down the treatment time substantially by having them come to us. So again, just to remind ourselves, what are our options for treatment? It's the IV thrombolytic therapy, 3 to 4.5 hours, right? Bridging therapy, the two together, and then endovascular treatment, 6 or 24 hours. So just to go down the memory lane for a moment, the sort of study that started this whole thing was the Nih Stroke trial, which was really looking at IV TPA versus placebo. This is in 1995 in terms of acute ischemic stroke. You must remember that before this time, there wasn't a lot going on. Certainly we used aspirin and things like that, but there were no acute stroke therapies to try to limit someone's disability after stroke. So this was really the landmark study. And just to remind you, again, 1995, so it was really divided into two parts, again, all stroke. So large vessels, lacunas, probably they had stroke mimics, everything. Everybody coming in, CAT scan negative, et cetera, but with focal deficits within 3 hours of symptom onset. So they had two different parts. I find this interesting because part one was looking at the difference between the two groups within 24 hours. So had they stopped the trial at that point, they would have seen there was no significant difference between the outcome of people who received IV TPA versus the people who didn't receive anything. But then they looked at 3 months at the two different groups to see whether there was any difference. And that's when they saw that there was a favorable difference between the group that received IV TPA and again, the group that did not. And ultimately, what it was shown is that people who received IV TPA were 33 to 50% more likely to have minimal or no deficits at 3 months. Now, this was huge because you think of a time where people came in with stroke, they had weakness, et cetera. I mean, it was unfortunate, but there was no real thing to offer. Versus now, it was an agent, a medication showing that you could give this within a short period of time window and have 33 to 50% minimal or no neurological deficit. So that really started off acute stroke treatment and the therapy of acute stroke as people came in. That's a landmark trial. You probably know, again, we discussed that we can extend for some patients to 4.5 hours. So 3 hours of symptom onset is FDA approved for IV thrombolytic therapy, TPA. But in some patients, we can extend the window to 4.5 hours after symptom onset. This was primarily from a European trial in 2008 that showed that there was some effectiveness by extending the trial. So you might think, oh, we sit back and relax and we wait for 4.5 hours. No. So we have to obviously still treat as soon as possible, but also there are a lot of exclusions to that. So even though it sounds like it might allow us to treat a lot more people, the exclusions are we can't treat people over 80 years old at 4.5 hours. So the reason is that there was an increased risk of hemorrhage during that time. Obviously, we can't use if someone has oral anticoagulants or high NIHSS. So NIHSS is sort of a shorthand of way we talk to each other in terms of the severity of the stroke. So 0 is normal, and then as you go higher, you have more neurological deficits. So someone who has a very large Nih Stroke Scale suggests that they have a large part of the brain affected and probably a large stroke. And then this is interesting. In the ECAS trial, they saw that patients with a history of stroke, so previous to them coming in, and diabetes had an increased risk of hemorrhage and doing badly. So if someone has a history of stroke and they have a history of diabetes, we can't extend to 4.5 hours. So really that extension of the window to 4.5 hours doesn't extend to a lot of people. So IV TPA works fairly good, but the problem with it is that it doesn't recanalize really well large vessels. So the large vessels are, you know, the carotids, middle cerebral arteries, basilars, vertebrals, et cetera. It does well on small vessels and things like that, but not as good. So the real question is, what else can we offer? And so we've turned to tenecteplase, which is, I guess, new and improved version of TPA. It has a higher fibrin specificity and longer half-life than TPA, and it allows for just a bolus. So you probably know that with IV TPA, we have to give the bolus injection, and then it's hung over an hour. With T&K, we just give the bolus over less than a minute and we're done, and we can go straight to the endovascular suite. So shorter preparation time, obviously shorter administration time, just a minute versus 1 hour. We don't need another IV. We don't have to have an IV infusion. We can go straight to endovascular. Again, bolus over just a minute or seconds, sorry, the concentration is different, dosage is different, et cetera. So what's interesting is that many stroke centers have transitioned, because we don't have time to go into all these studies, but there's several studies to demonstrate the safety and efficacy of tenecteplase in acute ischemic stroke. So this started people thinking, if IV TPA doesn't promote the recanalization that we want in large vessels, would we switch to TNK to see if we can have some recanalization? And actually Mount Sinai, all the sites switched over last April. So this is sort of the anniversary of that, from TPA to TNK. And since that time, several other large stroke centers have done the same thing, including I think Stanford, as well as some other places near us. So if we look at the American Stroke Association, they suggested that tenecteplase is a reasonable alternative in some cases with people who have large vessel occlusions and more severe strokes undergoing thrombectomy. So this is just what we said: alternative TPA, better recanalization rates, less treatment time, et cetera. But we still need the monitoring afterwards, right? You don't just give thrombolytic therapy and say peace and love, because the biggest risk is development of a hemorrhage afterwards. So you have to make sure the blood pressure is where you want it, obviously frequent neurochecks. Sometimes we do serial scans. They should be in a monitored setting, et cetera. So let's just give a brief case. So this is a 76-year-old right-handed woman who was admitted for dyspnea and lower extremity edema. She has all the risk factors, right? High blood pressure, diabetes, dyslipidemia, coronary artery disease, obesity, et cetera. And then during the ED, this isn't surprising for a stroke patient, ta-da, new onset atrial fibrillation. So not a shock, and obviously a significant risk factor for stroke. But she did not come in with focal neurological deficits. She was admitted, and then the next day at 8:30 a.m., she was found globally aphasic, left gaze deviation, and right hemiplegia. So a very large Nih Stroke Scale, and the LKW is last known well. So, you know, we were talking about time is brain. We need to sort of figure out where someone, what time someone developed the symptoms to start the clock, right? So if someone, just so you know, if someone falls asleep at night and they're fine, and then they wake up with a stroke, you have to take the time that they fell asleep as their last known well, even though during that time while they're sleeping, probably the stroke developed. But you don't know. So you have to take when someone either saw or spoke to the person, or the patient can tell them that they were well. Many times if people fall asleep at night, I usually ask them, did they get up during the night? Were they able to go to the bathroom? Or sometimes people get a drink of water, et cetera. And if they were fine then we can restart the clock. But that's the unfortunate thing of waking up with a stroke, that there can be some extension of time. So she was found at 8:30 a.m. and she had her last known well at 8 o'clock, had a large syndrome. So this would be a left middle cerebral artery syndrome. So we did the CAT scan, looked okay, obviously no hemorrhage and no evidence of a recent stroke. So we treated her with IV tenecteplase, but still, because of the large Nih Stroke Scale, the thought is that she has a large vessel occlusion causing this problem. So we spoke to endovascular. And this was a site that didn't have endovascular on site. So we're starting to initiate the transfer. She was intubated for airway protection, but after she received the TNK and she came in globally aphasic, she was able to follow some simple commands. So maybe getting a little bit better. At the transfer site, obviously we reassess again. We do usually another CAT scan to make sure there's been no changes. And we saw that, you know, not a dramatic change, but she have some ability to follow some simple commands and right-sided weakness, but still went to the endovascular suite. And at the angiogram, so the groin puncture is where they go in, right? And left ICA, as you know, is left internal carotid artery recanalization. So I didn't show, I'm sorry, the picture of the angiogram, but she had a left MCA stroke and she had a left ICA occlusion going into the MCA. So a pretty significant problem. But by the time she reached the site and they did the cerebral angiogram, they saw that it had recanalized. So I'll show you the left ICA, which you see here, totally open going into the MCA. There's some drop off of the distal M3. So you know how we talk about MCA, right? It's sort of different divisions. So M1, M2, A3 as we go out like a tree trunk, but really opened up nicely. So much so that the endovascular team didn't go after, right? Because the more distal the clot, so further away in a smaller vessel, it's harder to retrieve. So M1 and M2 are sort of easier to get. M3, M4, M5 is more difficult. So they did not intervene. And then 2 days later, this is a patient who came in globally aphasic, couldn't move the right side, and had a gaze preference. So the gaze preference was gone. She was sitting on bed, following all commands, no dysarthria, had some mild right leg weakness. So she had an NIH of 1. So she went from a 32 to 18 to 1. So the pretty significant only with tenecteplase. Now, I won't say that tenecteplase does that all the time, but it does have a greater degree of recanalization, which is why a lot of stroke centers have started to use it over IV-TPA for acute ischemic stroke. But we still have the problem of large vessel occlusions, right? So large vessel occlusions, although they only account for 15% of stroke, significant disability goes with it, right? 2/3 of severe disability and 3/4 of mortality from stroke. Because it's a large area, obviously we have a lot of swelling afterwards. Certainly there are a lot of complications associated with stroke sometimes. So a lot of morbidity and mortality from large vessel occlusion strokes. And if we look at the NIH stroke scale we were talking about before, a very low NIH stroke scale suggests sort of a smaller, maybe subcortical stroke, the things you would get from hypertension, diabetes, et cetera. But large NIH stroke scale suggests large vessel occlusions in the way that we just saw that example. So if you get very high NIH stroke scale, you're starting in your mind to think, is this a large vessel occlusion and should I be thinking of endovascular treatment? This is just an example of looking at the blood vessels. So if we look before and after, what's interesting from an endovascular perspective is that the pictures are not perfect, right? There's still some branches missing from that tree on the after, but it's a lot better than it was before in terms of the perfusion and certainly ability of blood to get to the brain. So you don't want a perfect picture, but you want better blood flow, as we discussed before. And this is treatment without treatment. So this is an MRI of the brain, diffusion weighted image. You know, probably diffusion actually shows us acute ischemic stroke very well. So with treatment, this is somebody who has a subcortical, relatively small in size stroke, versus without treatment, someone who has a left MCA occlusion is going to have a territorial, right, a hemispheric infarct with a lot of morbidity and mortality associated with it. So this is from the Wall Street Journal, and if it's in the Wall Street Journal, it has to be true, right? So in 2015, there was this breakthrough. We had obviously IV thrombolytic therapy for a long time. We were looking into neuroprotective strategies, didn't really work that well in stroke. And then suddenly all these endovascular trials started to show that if you use IV thrombolytic therapy and go into the artery in a certain period of time and take out the clot, people start doing well, particularly large vessel occlusions. So this is big news because for a long time at the stroke conferences, which we have once a year, International Stroke Conference, it wasn't that exciting. But now 2015, all these trials back to back. So the New England Journal of Medicine started it in, I think it was January 1st, 2015. And then there was a trial in February, then a trial in March, then a trial in April. So stroke moves slowly in terms of therapy, but this was a lot of information at once saying that the use of IV TPA with rapid endovascular intervention in selected patients with large vessel occlusions, people were starting to do very well. So you can't have a successful trial if you don't have a fun name, right? So they all had fun names. Mr. Clean, which I think is the best, Escape, Extend IA, Swift Prime, and Revasc. Again, all of these are looking at IV TPA, certain time window with stent retrievers, primarily endovascular treatment, and how well the people would do. So a stent retriever, just so we're all on the same page, is that it's not a stent that you leave in, right? It's a stent that you go in to promote revascularization, and then you bring the stent out, so you're retrieving the thrombus or retrieving the clot. And so this is an example. We start off with A, so that's a left MCA occlusion, so you know that by now. B is them going in and traversing that occlusion, right? So they're trying to deploy the stent to reopen it so they can promote revascularization at the time that they're pulling out the clot. So they're opening up the artery to allow blood flow at the same time that they're pulling out the clot. So they can do this in a matter of minutes once they get up to the lesion or the site that's occluded. And D is showing how much clot they actually take out with these stent retrievers. So it's pretty traumatic. And you really get to see, because most of the time they do this and people are not intubated. I'm sorry, not sedated, because they want people to tell them, can you move, etc. And so as they're pulling the clot out, people start moving their arm, they start moving around, etc. So it can be pretty exciting and significant when you see it. So even though we don't have time to go through all the trials, basically they all showed something similar, and this is going back to modified Rankin scale. So this is a scale that is really a functional scale used to show how well somebody can do things, right? Can they walk without assistance? Can they get out of bed? That type of thing. And so 0 is normal, and then 4 and 5 and 6 you don't want to be. But this was showing that having the stent retriever and the IV TPA, that group did better in terms of lower modified Rankin scales than the people who had received IV TPA alone, which was remarkable, particularly for large vessel strokes that we talked about had a natural history of doing poorly, right? Either you were in a nursing home, unfortunately, for a long time, and or you died from a large vessel occlusion before these therapies. So let's talk about a case. So this is a 69-year-old woman who had the onset of right-sided weakness while in the bathroom. And she took a few minutes to get to the phone to call 911, but she came to Mount Sinai West and stated her weakness was better, she thought, than when it began. So she was evaluated. She still had some problems. So she had a right facial weakness, some arm weakness. So certainly evidence of a stroke, and she received full dose IV TPA. This is when we were giving tissue plasminogen activator. But you know that stroke can fluctuate, etc. So despite us giving her the IV TPA, we slowly started to see that she was getting worse in terms of her arm, face, and her speech. Now, the first thing we have to worry about is that if we just gave IV TPA, could she be bleeding into the brain? So we did a CAT scan to make sure things are stable, but they were stable, but she was still progressing with her symptoms. So she went from an NIH stroke scale of 6 to an NIH stroke scale of 21, so suggesting a large vessel occlusion. So these are the CT scans, some of the scans that we did. There's no blood, there's no signs of a large stroke, but there is evidence of a problem on the CT scan. So I don't know how much you look at CAT scans. Obviously, I look at people's brains all the time. This is a brain that has a problem, and the problem is this. So that's the middle cerebral artery on the left, and I don't normally, or nobody sees the outline of the MCAs normally, unless there's a clot or there's very sluggish flow. So someone who's presenting with the left MCA syndrome, right? Left MCA, but right hemiplegia, globally aphasia, etc., and they have a clot in the left MCA, that's a big problem. So we call that a hyperdense MCA sign. Again, it's suggestive of either a clot and or sluggish flow, not allowing blood flow to get to that territory, and someone coming in. This is a large vessel occlusion problem. If we allow this to progress, that's going to be a large hemispheric stroke with all the neurological deficits that we discussed before. So this is the CTA that we did on her, and you can see that on the right side, the right MCA, we're able to follow out the outline, right? But the left side, there looks like there's a little piece missing. So that's the clot that you don't see. And if we do side by side, I think it's a nice demonstration of this is CT non-contrast on the left side. So you see the dense MCA sign on just the CT scan. And then if you look at the CTA, you see the loss of flow or the flow gap on the CTA. It's almost like a puzzle piece, right? That piece can fit into the other, where you see that someone's having a problem with their left MCA. So this is a stroke in the making, not a good stroke. Again, this was the scan that I showed you before, but this was from her showing that her whole left hemisphere, the whole left MCA territory, was at risk of infarcting because it was not getting enough blood flow. And she had a left M1. So that's the first division as you're coming off the ICA. So that means you're not supplying all the branches. If you think of it a vascular tree, you're not supplying any of the branches of the MCA, and therefore that's a large stroke. So she had time of onset that we knew, stroke syndrome, secondary to a large vessel occlusion, and had a target for us to go after. So this is her going to the endovascular suite, and this is the conventional cerebral angiogram. So again, you see the abrupt cutoff of the left MCA, similar to what we saw on the non-invasive CTA study. And this is them going in, traversing that, and sort of reopening. So you see distally now, right? A lot of better branches of the left MCA, so reestablish blood flow. And this is the MRI diffusion afterwards. So I told you that we're not expecting the brain to be pristine. Someone who's come in and having symptoms after a period of time is going to have some degree of the brain injured. So there's a stroke there, right? And it's a stroke involving the left MCA territory, but it is not a total hemispheric stroke. So this is a smaller stroke than you would expect from someone who had a left MCA M1 division occlusion. So it wasn't stopping her from having a stroke, but again, we were going after the ischemic penumbra to try to shrink that territory down and reduce the amount of brain involved and therefore the deficits. So we discussed that sometimes we see changes right after the procedure. So immediately after the procedure, the patient was talking right before she couldn't talk, and the arm was anti-gravity. So you know that she had some strength, but you're able to push it down fairly quickly. The following day, she was full strength. And then 4 days later, she was discharged home, not to a rehab, home, with an Nih Stroke Scale of 1. I think she had a minor facial weakness. She started off, you remember, she came in at 6, she progressed to 21, and then she went home with an Nih Stroke Scale of 1. So this is pretty indicative of the cases that we see, meaning it's tremendous because, as I said before, in terms of the natural history of these large vessel occlusions, before these therapies were available, this would be someone who would either be going to a nursing home long-term for long-term care and or died, right, from the large vessel occlusions. Now, this is someone that can go home, back to work, back to doing what they want, obviously enjoying their life and family. So pretty big treatment option. So just to go over again, you know, stroke is a constellation of things, right? So you just don't have a stroke and that's it. It's a stroke and then things develop over time. So you do expect, some fluctuation in someone's exam. They have to be monitored very carefully. The imaging helps us a lot in terms of the diagnosis and what the cause is, large vessel versus small vessel, and in terms of options. So the reason why we're running around like chicken without a head is that we want to try to get all these tests in a very short period of time in order for us to make the appropriate decision. So in order to be a stroke center, designated stroke center, which we are, if someone comes into the emergency room, there's a door to needle time. The door to needle time is someone hitting the door with symptoms and us deciding to give thrombolytic therapy. It used to be 60 minutes, right? Which isn't that long if you really think about it. Now it's 45 or less. So that's a very short time window for someone to come in, get the history, do the exam, do the imaging, make a decision, and get treatment. So that's why we're always pushing to get everything quickly, because we're trying to get the best outcomes as possible. So the better that and the faster that we restore blood flow, the more likely people won't be left with significant deficits. And then I just wanted to give, and then we can have some questions if you have any, about where we are. So I was saying in terms of stroke center certification, so both Morningside and West have stroke center certification, but every couple of years I have to recertify. So the difference, there's difference in terms of the level. There's primary stroke center, there's thrombectomy capable stroke center, and then there's comprehensive. So primary stroke center is the ability, obviously, to treat strokes and give IV thrombolytic therapy, also care for the patient afterwards, have rehab, and that type of thing. Thrombectomy capable is the next tier up, where you can obviously give IV thrombolytic therapy, but you have access to endovascular treatment. You also have access to an ICU, neurosurgery, and the endovascular team in order to be able to be a thrombectomy capable stroke center. And then comprehensive is all those things plus the ability to deal with subarachnoid, right? We only spoke about ischemic here, but people can present with subarachnoid hemorrhage from trauma or aneurysm rupture, et cetera. And so Mount Sinai East is a comprehensive stroke center. So Mount Sinai West will be going for its thrombectomy capable stroke center certification, and Mount Sinai Morningside will be keeping its primary or recertifying it as a primary stroke center. There's specific guidelines, as we've talked about, not only for the treatment of acute stroke, but also management of TIA acute stroke. Are they on antiplatelet therapy, anticoagulation? Have they had a look at their heart? Have they had a dysphagia screen, some other things? So all those things are important. There's a stroke order set and a stroke discharge set. that is important and the stroke team uses. I would like at some point, then this is primarily for Morningside, since the stroke team there is still a consultation service, that to work with your chiefs and some of you so that you know what the order sets are, what we're looking for, et cetera. Also the discharge summary, there's a specific discharge that puts in basically a lot of the information that we need. What is the person's specific stroke risk factors? Who are they seeing? For instance, if I saw the patient in the hospital, I would see the patient as an outpatient. So we like that continuity of care and like for the patient to know who they're seeing. And then there's certain documentation in terms of their functional status, both with MRS and the Nih Stroke Scale. And the last thing is, you may or may not be aware, there's been some uptick in the number of inpatient stroke codes. One, because I think that there's more knowledge and identification of stroke. Also, two, we have the ability to treat fast, et cetera. So there've been an increase. There didn't used to be a lot of inpatient stroke codes, maybe because people didn't recognize and we didn't have the tools. Now there are a fair amount. So speaking with Dr. Shapiro, ICU, the RRT team, that for inpatient stroke codes, stroke code and RRT will be called together in order to allow for more rapid assessment, particularly at night when there are less people in the hospital. And also the ability to triage, meaning do we need to get this patient to the neuro ICU? Do we need to transfer out to another site, et cetera? So that's something that we've spoken with the ICU and the RR team about, and we've made some changes in the protocol. So I think I can end a little earlier. That's me in South Africa on a lion reserve. So this is maybe the bravest I've ever been in my life, with a real lion and only my Yankee hat to protect me. But it's probably one of the best trips I've ever had in my life. So if you ever get to go to South Africa and go on a safari just to look at the animals, I suggest that you do it, because it's an incredible time, and I will always remember it. So I like to end with seeing the lion roar and me not being eaten. So if anyone has any questions, stopping a little early. Sorry that I had problems with my slide, but I appreciate your attention.
Yeah, I have a few questions. So I always notice that, someone will come in, they'll have stroke symptoms, they'll do the CT non-con, they'll get a CT angio, and then oftentimes it'll be negative. And then I guess I see they get MRIs, but the MRIs are never urgently done. Like, why is that? Why do they always wait till the next day? And also, what's the threshold to give, like, empirically give the TPA, even if there's no imaging evidence of a stroke?
Well, that's what we want to see. We don't want to see a CT scan with a well-delineated stroke, because then they don't have a penumbra anymore, right? They don't have a target. So we really want to see a CT scan within a certain time window, so 3 hours, 4.5, et cetera, that has no stroke but deficits, because then we know we're early enough to try to make a change. And so many times if someone comes in out of that window, that thrombolytic window, and they're not a candidate for endovascular, unfortunately they fall into, for acute stroke treatment, they are not a candidate for that. They have to come in. The reason why we do the MR later is because we want to see, is there a stroke that we're missing on CT? I think I mentioned earlier that if someone comes in either with dramatic focal neurological deficits with a few hours or just even 12 hours or so, CAT scan is going to be negative, but we know that there's a stroke that's not well visualized on CT. So the reason to do the MRI ultimately during the hospitalization, and it's not something that has to happen right away, is to give them an idea the degree of brain injury, because that also relates to their ability to recover. Sometimes we see old strokes, right? So if I see someone had an old stroke in their left frontal and now they're coming in with a right frontal stroke, I may think that they have some cardioembolic phenomena, because they're having now strokes in different vascular territories over time. So it allows us to see the brain and determine whether we think that all these strokes are related that someone had. So the MRI is not urgent, because it doesn't necessarily help us with the acute management, but the CT, CTA, we're hoping not to see a stroke, and we're hoping that the person comes in within a period of time so that we can treat them with therapy that's shown to be effective. Did that answer you?
Yes, partly.
Mm-hmm.
The other thing is, so you're hoping to not see a stroke, so you're not actually looking for an occlusion in the vessel. So CT angio.
No, I'm sorry. I was talking on CT scan. I'm sorry, I wasn't clear then. The CT brain scan, we do not want to see a stroke, because that would suggest there there's not an infarct and we still have a penumbra to go after. So on the CT non-con, the best thing is to see no hemorrhage, no recent stroke. On the CTA, we're looking to see, do we see an occlusion, right? Do we see an MCA occlusion, ICA, basilar, vertebral artery, et cetera? So if we see nothing on the CT brain scan, but we see large vessel occlusion, that's the candidate for endovascular therapy and maybe thrombolysis. But if we see a completed stroke on CT, even if there's a large vessel occlusion, it's likely that that patient is not a candidate. We would do a penumbra study, meaning we would do a perfusion study to see if there's still a target. But usually a completed stroke that we can see well on CT is many hours later. Maybe we don't have the time of onset right, et cetera. So those patients wouldn't do well. Because if you open an artery to a part of the brain that's been recently injured, you're just going to increase the risk of hemorrhage into the dead tissue and the blood vessels that the integrity is not as good anymore.
Okay, that's helpful. The only thing is, like, if, so say it's not a bleed, but like, I guess if you have someone who the CT head non-contrast is negative, and then you do the CT angio and you don't see anything, but they still have focal symptoms. So like, you're not seeing an occlusion.
Right. So they might be a candidate for just IV thrombolytic therapy. But for IV thrombolytic therapy, it's the risk and benefit, right? The benefit is to try to improve their focal deficits. The risk is hemorrhage. So not every stroke that comes in with focality gets IV TPA or IV TNK. You should have pretty significant deficits, meaning not just facial weakness and nothing else, right? Because if that's from a stroke, and it might be Bell's and other things, but if that's from a stroke, it's a very small vessel stroke deep in the brain, and those from a natural history do well. But if someone comes in with, let's say, hemiparesis, arm and leg, a little bit of dysarthria, that's probably, again, a subcortical stroke due to small vessel disease. And those patients would have an Nih Stroke Scale of 5, 4, 6. Those would do well with IV thrombolytic therapy if they're coming in within the 3-hour, 4.5-hour window. So in that case, we probably wouldn't see something on CT. We wouldn't see a large vessel occlusion because it's not secondary to that. But that patient would be appropriate if they come in within that window for IV TPA, as long as they don't have all the other exclusions that we mentioned.
Okay, that was very helpful. Now I understand.
Thank you. Other questions?
And along those lines that John mentioned, these patients that aren't candidates, CT is negative, CTA is negative, and what if they have a contraindication for MRI? They have some shrapnel or metal. Besides from giving them antiplatelets and aspirin, are there any other options for treatment and mainly imaging for these patients?
Well, you know, MRI is, first of all, I hope all you know that just having a pacemaker doesn't mean that your MRI, you can't have it at all, right? So over the past few years, many of them are MR compatible or MRI conditional. So you just have to find out, is that true? The other thing is, if someone has a bullet and it's isolated, depending on where it is, so that isn't totally a contraindication, it depends on where. Shrapnel is a little bit more concerning because obviously that means it's several different places, and the problem with MRI is that it's going to heat up those places, right? So depending on where it is, that obviously might be a contraindication. So in answer to your question, you're right. Sometimes we can't do an MRI for a variety of reasons. We would then say, let's repeat the CAT scan in a day or so, because even though the CAT scan doesn't show it early, it does ultimately show a stroke. It just takes some time to show it. So we might say, repeat the non-contrast CT in a day or so, and we'll see it then. In terms of treatment, it depends on the etiology, right? If someone comes in and they have strokes, as I say, an old stroke or new stroke, or strokes in different territories, we're going to think that's more embolic in origin. So you think sort of heart from a cause, maybe from atrial fibrillation, or somebody has a hypercoagulable state that might need anticoagulation more than they would antiplatelet therapy. So antiplatelet therapy, aspirin, clopidogrel, et cetera, are sort of reserved for small vessel strokes, the lacunar strokes, which you've heard about, that cause some symptoms subcortical in the brain. But anticoagulation is reserved for strokes from atrial fibrillation, some strokes secondary to dissections, which you've probably seen, to promote recanalization, et cetera. So it really depends on the etiology or the cause of the stroke that we decide antiplatelet versus anticoagulation, how long. You know, sometimes we use dual antiplatelet therapy up front, and then we subtract one of the therapies later on, because there was a trial that showed with some specific strokes using aspirin and clopidogrel for 3 weeks or so after the stroke improves their overall function for a period of time. And if you keep it on longer, it might increase their risk of bleeding. So there's a lot of sort of nuances with treatment afterwards, but the MRI thing is problematic if someone has a pacemaker or has metal inside of them that we can't get approval for. You're correct.
Thank you.
Thank you, Dr. Brockington. Can you comment on the physiological differences between tenecteplase and TPA? Why do we see recanalization with tenecteplase but not with TPA?
I think it's because it's more fibrin specific. And so that specificity and time of action, the two differences between the two agents suggest that it would promote more recanalization. So it can go after the thrombus that's there in a large vessel occlusion where TPA probably cannot. And so the case that I showed you is not just one case. I mean, we've had several cases that we've given tenecteplase, thought it was large vessel, send them to endovascular, and endovascular says, where's the large vessel occlusion? So pretty good, doesn't happen with everyone, but we want to try to give people the best option, right? So if they do come in, we give them tenecteplase and send them immediately as fast as we can to endovascular to see, can they recanalize, can they reopen? And so sometimes it is already reopened, sometimes they need to go after it. They do think it's a little bit easier sometimes to recanalize with the tenecteplase on board, but we've had fairly good results over the past year that we've been doing the two together.
I want to thank you, Dr. Brockington, for a very informative lecture. I'm sorry that I interrupted you. Did you mean to say anything?
Oh, no, I'm sorry that my technical ability is very poor, but I hope the slides came across well, and I was able to give you some information regarding stroke, but I appreciate the invitation. Thank you.
Absolutely. May I pick your brain on something, Dr. Brockington, if you don't mind? I know that we're almost running out of time.
Sure.
But you did mention this before, and we are seeing more stroke codes called in our inpatient units. And let's say we're interns on a floor. I would like to ask you what you would recommend once we've ruled out hypoglycemia in these patients and we notice there's a new focal deficit. What would the best way of triaging these patients, and what's the best next step in getting these people to the correct treatment options, just to help our neurology colleagues?
I think call a stroke code if you even think about it, meaning that nobody's going to be upset that we come and see and we say, oh, that's Bell's or this or that. Because if you're right, then that saves us time and we can go very fast and really treat patients versus, if you're wrong, big deal. I mean, so we've all been wrong, right? But when we say time is brain, we really mean it. We have a very limited period of time to make all these decisions and get all these pretty complicated testing done. So if that's on your differential, and if you're worried and you saw the person and they look different and now they're not speaking well, they're not moving well, etc. There are not many things that do that acutely, right? Stroke is 1, 2, and 3 on that list. Certainly there are other things that can mimic stroke, but you need to really rule out stroke before you go into those other things in the differential. And so I think nobody would fault anybody from calling a stroke code, and we actually want you to call a stroke code because we can take a look and make a decision in conjunction with you and hopefully save someone's brain, right? So I think it's not a mistake to do that. And we, as I say, I see the brain all the time, so I'm more used to seeing it than you guys. So call us. We're here, we're available, and we're happy to partner with you.
That's definitely reassuring. Thank you so much again, Dr. Brockington, for coming.
Thank you, everybody.